Okay, welcome to the deep dive. You brought us your revision notes, and we're focusing specifically on syphilis today.
Yep.
So that's our plan. Really unpack these notes, find the absolute must-know stuff, and make it easier for you to remember for revision. Think of it like turning your notes into a quick audio guide.
Exactly. And it's really timely. Syphilis isn't just something in old textbooks. We're actually seeing a big resurgence globally and, importantly for us, right here in the UK. So getting a good handle on it is pretty crucial. We'll
Yeah.
basically follow your notes, what it is, how it gets around the body, what it looks like, how we figure it out, and how we treat it.
Perfect. So let's start right there. The definition. At its core, what are we talking about with syphilis?
Okay, so fundamentally, it's a sexually transmitted infection, an STI. But the
Yeah.
specific cause is a bacterium called Treponema pallidum.
Treponema pallidum. Got it.
And the really key thing to grasp is that it's not just like a local infection. It's chronic and it's systemic. That means this bug doesn't just stay put. It travels. It can affect loads of different organs, different body systems over time, and it does this in stages.
Ah, okay, systemic. That's important. So how does this bacterium actually get in and, start moving around?
Usually through really small breaks in the skin, maybe ones you wouldn't even notice, or it can get through intact mucous membranes. So most often during sexual contact, once it's in, it's pretty good at spreading. Uses the bloodstream, the lymphatic system, gets around the body quite quickly, actually.
In your notes, immediately flag some, well, pretty serious consequences.
Yeah.
The first one that really stands out is this link with HIV.
Oh, absolutely critical, yeah. If someone has early syphilis, it makes them much more likely to transmit HIV if they have it or to acquire HIV if they don't. Which is why, and your notes nail this, if you diagnose syphilis, you have to test for HIV, period. And the other way around, too, people in HIV care, they need regular screening for syphilis. The two just unfortunately go hand in hand sometimes.
Okay, that's definitely a high-yield point then. Syphilis means test HIV, HIV means screen for syphilis, and the other really devastating outcome mentioned.
That's congenital syphilis. So when the infection passes from a mother to her baby during pregnancy or during childbirth, it's a huge cause globally of stillbirths and serious illness and death in kids. Preventing that is like a major public health goal. We'll probably circle back to that.
Yeah, so key takeaways early on. Remember the name, Treponema pallidum. Think systemic traveler, multi-stage disease, and that vital HIV link, plus the tragedy of congenital syphilis. Your notes then classify it acquired versus congenital and break down acquired syphilis by time.
Exactly. So the acquired form, the one people usually get later in life, it goes like this. First, primary syphilis. This shows up typically maybe 2-3 weeks after you get infected, but the range is huge. Could be anywhere from 9 days to like 90 days. That's the initial, usually local stage.
Okay.
Then comes secondary syphilis. That's a bit later, maybe 6 to 12 weeks, sometimes up to 6 months post-infection. This is when it's really generalized, spread through the body.
Right.
After that, you can enter latent stages. Early latent means no symptoms, but it's within the first 2 years. Late latent, also no symptoms, but it's 2 years or more after infection.
Still hiding out.
Exactly. And then potentially years, even decades down the line, you can get late symptomatic or tertiary syphilis. And that's when it hits major systems, cardiovascular, neurological, or causes these things called gummas.
And congenital syphilis has its own timeline, too.
Yep, much simpler, though. Just early congenital, symptoms in the first 2 years of life, and late congenital, symptoms appearing after age 2.
Okay. Your notes suggest a revision tip. Link those incubation times and the no symptoms part to the latent stages. Seems useful. Let's move to how it spreads, etiology, and transmission. We know the bug. Treponema pallidum, main routes.
Yeah, overwhelmingly, it's sexual contact. Vaginal, anal, oral sex. Direct contact with an infectious sore or lesion. That's the main way it passes between adults.
And the other key route.
The mother-to-child one we mentioned. During pregnancy or birth, leading to congenital syphilis.
Understanding that naturally makes you think, okay, who's more likely to get this? What about risk factors in your notes?
Right. So the notes list a few things. A lot relates to sexual activity, obviously. Things like unprotected sex, having multiple partners, having had other STIs before, certain sexual behaviors that carry higher risk. And being a man who has sex with men, MSM, is highlighted as a group with higher rates currently.
Grouping those sexual factors makes sense for memory. What else is mentioned?
Also things like drug use, particularly injecting drugs. And just geographically, living in or being part of a community where syphilis rates are known to be high.
Okay. So we know the what, the how it gets in, the who's at higher risk. Now, pathophysiology. How does this tiny bacterium actually do the damage?
Right. So we said it spreads systemically, bloodstream lymph, it gets into organs, into tissues, and it's really the body's reaction to this invasion, the inflammation and immune response, that causes a lot of the symptoms we see in the different stages.
But it can also hide, you said.
Exactly. That's a key part of its success, if you like, immune evasion. Treponema pallidum is weirdly good at hiding from our immune system. It can lie low, dormant, sometimes for years, decades even, which is why if it's not treated, it can pop up again much later and cause those serious tertiary complications.
That ability to spread and hide, that explains a lot. Explains why it's called the great mimic, like your notes say. Which brings us nicely to differential diagnosis. What else might look like syphilis? This sounds tricky.
Yeah, it's super important for revision because syphilis can really look like a lot of other things. You've got to think broadly. Other STIs, sure, but also non-infectious stuff that causes similar signs, like ulcers or rashes.
Your notes helpfully break it down by stage. For primary syphilis, with that classic painless chancre, what else could cause an ulcer like that?
Okay, so for primary, your notes list things like herpes, ulcers, especially in someone with HIV, they might look a bit different. Chancroid, LGV, which is lymphogranuloma venereum, and donovanosis. All infections causing genital sores. Distinguishing them is key.
And for secondary syphilis, with the rash, that famous palms and soles rash?
Yeah, well, the rash can vary a lot, but common mimics are things like pityriasis rosea or different kinds of viral exanthems, basically viral rashes. Honestly, any widespread rash, especially if it includes palms and soles, syphilis has got to be on your list.
Tertiary must have a massive differential then, hitting organs like that.
Oh, huge.
Yeah.
The notes basically say any unexplained heart problem, any weird neurological sign or symptom. Think syphilis. Could it be syphilis? The list of possibilities is enormous, so you really need a good history, good exam, and the right tests. A memory trick here is like, see an ulcer, think primary mimics. See a weird rash, think secondary mimics. See strange neurocardiac stuff, tertiary. Definitely consider syphilis.
That's a practical approach.
Yeah.
Now, the bigger picture. Epidemiology.
Yeah.
Why is this so relevant now? You mentioned the resurgence.
Yeah, because the numbers are going up significantly. Your notes quote about 10.6 million new cases globally each year, which is, a lot. But it's happening right here in the UK, too.
And the UK stats in the notes are pretty stark.
They really are. Diagnoses in England basically tripled in the decade leading up to 2019. And while it affects everyone, the numbers show a big impact on men who have sex with men, MSM. They accounted for, 78.4% of diagnoses in 2019.
Wow.
Yeah. And rates are highest in cities. London, Brighton, Blackpool, Manchester, Salford are mentioned.
So the takeaway is, this isn't ancient history. It's a current, growing public health issue, especially in certain groups and places, which makes recognizing the clinical presentation absolutely vital. Let's walk through the symptoms, stage by stage, based on your notes.
Okay, primary syphilis, classic sign, the chancre. Remember, typically painless. Firm, round ulcer, usually on the genitals, but could be elsewhere. And you might get swollen lymph nodes nearby, inguinal lymphadenopathy. But that painless nature, that's the classic buzzword.
Right, painless ulcer. Secondary syphilis is more widespread.
Yeah, this is the systemic stage showing itself. The rash is key. Super variable, could be faint, could be obvious, but classically includes the palms and soles, that's high yield, other stuff, fever, sore throat, feeling generally unwell, muscle aches, maybe some mouth ulcers. Oh, and these specific warty-looking lesions in moist areas, like around the genitals or anus, called condylomata lata.
Condylomata, okay. So rash on palms and soles, think syphilis.
Yeah,
got it. And tertiary symptoms.
These depend on where the damage is happening years later. You might see gummas. These are like chronic inflammatory lumps that can destroy tissue anywhere in the body. Cardiovascular syphilis often means aortic problems like aneurysms. And neurosyphilis, well, that's the brain and nervous system, can cause anything from personality changes, dementia, problems with balance, sensation, vision, hearing, serious stuff.
And the notes have those very specific, kind of memorable signs for congenital syphilis, too.
Yeah, these are worth knowing. They often pop up in exams. Hutchinson's teeth, they look notched or peg-shaped. Brigade's little linear scars around the mouth. Interstitial keratitis inflammation in the eye's cornea. Saber shins, where the shin bone, the tibia, bows forward. That saddle nose deformity, a flattened nasal bridge.
Yeah.
And deafness. Seeing those signs in a child is a huge red flag for congenital syphilis.
It's also crucial, as your notes imply, that symptoms can just go away on their own, but the infection's still there.
Exactly. Symptoms, especially in primary and secondary, can resolve without treatment. But the bacteria are still lurking. It can then come back later or progress silently to the later stages. And yeah, neurosyphilis can be sneaky. Sometimes it's asymptomatic or causes very subtle problems initially.
So a good self-test, like you said.
Mm.
Painless ulcer. Primary syphilis, high on the list. Rash, including palm soles. Think secondary. Good pointers. Okay, we suspect it. How do we prove it? Investigations.
Right. Diagnosis mostly comes down to blood tests. We group them into two main types: treponemal tests and non-treponemal tests. Sometimes, if there's an active sore, we can try and find the bacteria directly from that.
And that critical point about testing for other things.
Absolutely essential. Cannot stress this enough. If you're testing for syphilis or you've diagnosed it, you must screen for all other common STIs, especially HIV. It's just standard practice, good practice. Sometimes you might need more tests, like a lumbar puncture, a spinal tap if you suspect neurosyphilis, or imaging like CT or MRI for brain or heart issues.
Okay, let's break down those blood tests. Treponemal tests, what are they actually looking for?
So treponemal tests look for antibodies that your body makes specifically against the Treponema bacterium itself. Your notes mention ones like EIA, CLIA. Those are often the first screening tests run. They're very sensitive. Others like TPHA, TPPA, FTA-ABS are often used to confirm a positive screen. Basically, a positive treponemal test means you've been exposed to syphilis at some point in your life. They usually stay positive for life, even after treatment.
Okay, so they show exposure. What about the non-treponemal ones, like VDRL or RPR?
These are different. They measure antibodies against stuff released by your own cells when they're damaged by the syphilis infection, not directly against the bug. The key thing about VDRL and RPR is their level, or titer, usually reflects how active the infection is.
Ah, so they measure activity.
Exactly. And crucially, this means we can use them to see if treatment is working. After successful treatment, the titer, the level of these antibodies, should go down significantly, maybe even become negative. So, memory tip. Treponemal exposure usually stays positive. Non-treponemal activity used for monitoring.
That's a clear distinction.
Yeah.
And direct detection.
Yeah, less common now maybe, but especially with a primary chancre, you can sometimes take fluid from the sore and look under a special microscope, dark field microscopy, to actually see the spiral-shaped bacteria. Or use other lab tests like DFA or PCR on the sample. So know the difference. Screening, EIA, CLIA, confirmation, other treponemals direct, monitoring, non-treponemal.
Right. Diagnosis confirmed. How do we treat it? Management.
The absolute main player is antibiotics. And the gold standard, the best treatment particularly for early syphilis, is an injection of benzathine penicillin G. Just penicillin. The exact dose, how many shots you need, that depends on the stage, early, late, neurosyphilis, etc.
Simple enough. What if someone's allergic to penicillin?
Good question. Doxycycline, an oral antibiotic, is the main alternative listed in your notes.
Okay. The notes also flag something called the Jarisch-Herxheimer reaction. What's that? Is it dangerous?
The JH reaction. Yeah, it can happen a few hours after the first dose of antibiotics, usually penicillin. You suddenly feel worse, fever, chills, headache, muscle pains. Maybe the rash looks worse for a bit.
Sounds alarming.
It can be, but it's thought to be caused by the massive die-off of the bacteria releasing inflammatory stuff all at once. The important thing your notes mention is that it's usually self-limiting. It settles down on its own within, say, 24 hours. You manage the symptoms, but it's not usually a reason to stop treatment. Just something to be aware of and warn patients about.
Good to know. Beyond the antibiotics for the individual, what else is involved in managing syphilis?
Oh, contact tracing is huge, really important. You need to identify anyone the person might have had sexual contact with recently, get them tested and treated if needed, even if they have no symptoms. That's how you break the chain of transmission.
Makes sense.
And then there's the public health side, promoting safer sex, encouraging regular screening, especially in high-risk groups. Condom use helps prevent transmission.
And that vital prevention point for congenital syphilis.
Right, back to that. Routine antenatal screening. All pregnant women in the UK get offered a syphilis test as part of their standard pregnancy care. It's incredibly effective at catching infections in mums and allowing treatment to prevent the baby getting infected. So, key management points. Penicillin first choice, doxycycline alternative. Watch for JH reaction, contact trace, and routine screening in pregnancy.
Okay. Prognosis, what's the outlook?
Well, the good news is if you catch it early and treat it properly, the prognosis is excellent. Syphilis is completely curable with antibiotics.
But the flip side, if it's missed or treatment is delayed.
That's where the serious problems start. Untreated or inadequately treated, syphilis can lead to those severe long-term complications we touched on, which your notes list out clearly.
And these are the really nasty ones affecting major systems.
Exactly. You've got neurosyphilis, damage to the brain, spinal cord, nerves, cardiovascular syphilis hitting the heart and especially the aorta, gomatosyphilis, those destructive lesions, and of course the devastating effects of congenital syphilis if a baby is infected. These aren't trivial. They can cause permanent disability or even death. It really hammers home why catching and treating it early is so vital.
It really does connect back to that pathophysiology, doesn't it?
Mm.
The way it spreads and hides allows these late complications if it's not dealt with.
Precisely. It's a long game if left untreated.
Okay, well, that brings us through a really thorough deep dive into your syphilis notes.
Yep.
We've covered the bug itself, how it gets around, the stages, how it looks, how we test for it, treatment, and those potential long-term consequences. Hopefully, breaking it down like this, using those memory cues, and thinking about how questions might be framed, makes it all feel a bit more manageable for your revision.
Yeah, and we've seen it's curable with something as simple as penicillin, yet cases are rising quite dramatically.
Which does leave that interesting question to think about. What does this resurgence actually tell us about where we are with sexual health awareness, public health strategies, and maybe access to care in society today? Something to mull over.
Definitely a complex issue. Well, thank you for bringing your notes for this deep dive.
And listen, as you're cracking on with your revision, especially for the MSRA, you might find passthemsra.com and freemsra.com really useful. They've got loads of practice questions, mock exams, things like that, specifically tailored for it.
Yeah, definitely worth checking out. Best of luck with all the studying.
From the D-Jive, that's it for this session.